Okay, so I'm going to talk about imaging traumatized brain, or at least detecting certain kinds of intracranial bleeds based upon cardiac-driven pulsations of brain that we can measure with ultrasound. The application is for TBI, but Mike Levitt and I are exploring the possibility of using this for stroke. So the Department of Defense has a very specific problem. At a minimum, the minimal viable product would be a handheld device that can detect the presence of different classes of intracranial bleed for triage purposes, because they got to decide if they're going to medevac someone out, in what order to medevac people out. So if you have an epidural bleed, that's great. Your clinical outcomes are likely quite satisfactory. You'll go to the head of the line. If you have an interparenchymal bleed, well, the outcomes are not so good, and you'll be at the back of the line for medevac. So we have a device. It's the size of an iPad mini with a keyboard and a probe. It's FDA-approved ultrasound. For diagnostic purposes, we do some novel analysis to pull out pulsations of the brain. Here's an example, imaging through the temporal window. This is an axial cut. There is the brainstem right there. If you focus on a pixel that's about 1 millimeter across, you can measure cardiac cycle influenced brain tissue pulsations with peak values that typically scale around 50 microns. And for a reference, your average human hair is about 100 microns in diameter. These are really small pulsations, but we can pick it up with ultrasound. I'm going to show you our intrapatient retrospective analysis now. In other words, we derive results for a given patient, and what we seek to do is recruit more test subjects for more imaging. We have about 60 now, and we're aiming for about 120. And we're working towards an interpatient prospective algorithm using machine learning. So what we learn about the pulsations of different kinds of lesions relative to healthy brain will, we hope, lead to a prospective algorithm and a device that in real time images, at least detects different kinds of brain lesions, if not images them. Briefly, the data set we have on your left is an ultrasound image, temporal window to the top of this baseball field-like shape, skull along the bottom, and some vague shapes in the middle. This is standard diagnostic ultrasound. Through a lot of work, we align the patient's CT image, a slice in the patient's CT image with that diagnostic ultrasound. So red is skull, of course. This lime green in this case is a subdural bleed, I believe. There are the ventricles, brain tissue. In the next step, this is a complicated slide, but I will take only a minute for it. We project the CT-defined blood, which is yellow, versus non-blood, which in this case is purple, onto the ultrasound data. We then derive a single metric for what is blood based upon analysis of the pulsation of brain across all those blood pixels as defined by the CT. We define another single metric for what is non-blood, the portions of the ultrasound image that the CT says doesn't have blood. With that single metric for blood versus non-blood, we then apply it to every pixel of that same image and then ask what's the likelihood we've detected blood, where there's variation in the pulsatility of brain thanks to the presence of blood, thanks to all kinds of things. So upper left is what the CT would say is blood in this retrospective analysis. Lower right is what our algorithm would say, pixel by pixel, what is blood and what isn't blood. So in this case, we have a subdural bleed, I believe, and we pick out that bleed very nicely. We do have false positives relative to CT, small motes scattered throughout the brain, and among the art for us is to optimize this ability to detect blood versus non-blood prospectively and to remove these false positives. I'm now going to show you several examples, and then I'll have an ask for help. So here's an example of an epidural bleed. There's the CT up in the middle there. There's the green that is the CT-derived blood, and here is our retrospective analysis that identifies that same bleed with a very good area under the curve. We could call this an image of an epidural bleed. Here's one which I call a subdural and subarachnoid bleed. I think that's subdural. I think that's a subarachnoid bleed, but this is where I need help. This is what the CT declares is blood. This is what the device declares as blood. So we follow the what I'm calling a subdural bleed in arachnoid space. But remember, our goal is to detect at a minimum, ideally to image. Might someone reading this declare that an interparenchymal bleed? They would lead to a different triage decision. So hence one of our concerns and need to improve the algorithm. Here's another one, subdural bleed. Again, this is what the CT declares is the subdural bleed in this retrospective analysis. This is what our algorithm picks up, but we have a couple, at least this one, fairly compelling from an algorithm perspective interparenchymal bleed, which doesn't exist for this patient. This patient would be misdiagnosed, mistriaged. Here's another one. Here's a big interparenchymal bleed with a couple subarachnoid bleeds. We do a decent job of imaging it. So that the call would be interparenchymal, triage last. We missed the subarachnoid bleeds. For this patient, it wouldn't matter. As far as the triage decision goes, they have a big intraparenchymal bleed. They go to the back of the line. Same patient, imaging from the other side of the skull. We could argue that we detect the interparenchymal bleed. Here again is the CT. Here are some subarachnoid bleeds. And we actually image some of those subarachnoid bleeds, but I think they perhaps would be called subdural bleeds. For the purposes of triage, this would be a 6-1 subarachnoid bleed by CT. Here it is again. We would detect this as an interparenchymal bleed. We would mistriage them, although the outcomes for each of these are not so great. There's an intraventricular bleed. Here's the last one that I'll show you. This poor patient was a mess. We actually did image this subdural bleed here to a decent amount. We have a complete false positive here, falsely detected an interparenchymal bleed, and probably we would identify these interparenchymal bleeds as subdural.
Can we wrap up conclusions?
Yep, right now. I seek help to help me identify patients. John Williams did an excellent job. Here are some examples of his turgid prose. I seek a collaborator to help identify these features in pulsatility versus CT and develop special operating procedures for detection. That's it.
That's wonderful. Thank you for a look at your work.
I'm going to try to rapid fire through 3 different projects we have going on in our lab, and they all revolve around this concept of mosaic variability, really focusing on allele frequency and the pathogenic nature of variants in certain genetic alterations. So as a skull-based surgeon, we have the difficulty of treating lesions at the base of the skull with a complex variety of tissue, including blood vessels, cranial nerves, bone, and actually very important brain. A lot of the questions in our group revolve around a clinical question or a quandary. And really we rely on the tumor banking and vascular banking that we employ at all of our hospitals. So we've actually banked about 200 or 2,000 independent patient samples since 2011, and there's probably another 3,000 prior to that time that started with Bob Rastomoli and Dr. Silber. I'm going to try to get to 3 very quick stories, and I have my alarm on here, but 3 that really focus on the skull base, and 3 independent pathologies that we see. 1 is aneurysms, 2 is the pituitary tumor, and then 3, this concept of the inability to predict outcomes and recurrence rates in meningiomas, despite our neuropathology colleagues. So again, to put it into context, if you think about mosaicism, really a genetic alteration can happen anytime during development, at the level of the zygote all the way up into adulthood. With NF2, if the mutation happens in the germline, then every cell in the body has the potential to form a meningioma or a schwannoma. If it happens in a sporadic event, then you get the sporadic acoustic neuroma or the sporadic meningioma. Regional mosaicism, the really classic example is Sturge-Weber syndrome. And I remember as a medical student, everybody saying that there is no genetic alteration that causes this syndrome that all our pediatric colleagues see. And in fact, it was the advent of deep exome sequencing that led to the discovery of a mutation in GNAQ in a very, very low allele frequency. Historically, we think about loss of heterozygosity, and 50% of the alleles have to be altered to cause a pathogenic entity. But in fact, this manuscript in the New England Journal showed that allele frequencies in the region of the pathology can be as low as a fraction of a percent and cause this devastating phenotype. We ran across a patient who displayed external manifestations of what we thought was a genetic issue. He had a dissecting carotid aneurysm at the age of 9, and everybody knows that's odd, and came to the University of Washington for treatment of this large growing vertebrobasilar aneurysm. And all of his internal vascular malformations were under this external skin phenotype. He was seen by many famous people throughout the country to try to diagnose him, including Peter Byers here of Ehlers-Danlos fame, with no diagnosis. He actually had surgery here with multiple specimens harvested at the time of surgery, including normal peripheral blood, normal artery, normal skin, abnormal skin punches. And with deep exome sequencing, we found an alteration in a gene that happens to be a kinase called PDGFRB in a hot spot on amino acid 562. In his normal tissue and normal blood, it was absent, essentially making the diagnosis of classic mosaicism. What was even more important is that we actually screened a plethora of samples collected by myself, Dr. Kim, Dr. Shaker, in our vascular and tumor bank for alterations in PDGFRB, and other sporadic non-mosaic patients harbored very similar mutations in the kinase and juxtamembrane domain of PDGFRB. Since this time, we have a very ultra deep sequencing technology called digital droplet PCR that allows us to get down to about 1 in 1,000 reads. And I can tell you with confidence, 100% of human fusiform aneurysms, and this is up to about 100 samples, have alterations in PDGFRB. This is very interesting because when somebody has a germline mutation in PDGFRB, you can have a syndrome called infantile myofibromatosis, where they don't form aneurysms, but they form tumors. And those tumors actually histologically are very similar to hemangiopericytomas. And in fact, when you sequence hemangiopericytomas, you find alterations in this same exact gene down to allele frequencies of 1 in 1,000. So again, cell-specific, allele-specific, and pathogenic nature-specific alterations can give you completely different phenotypes. The unifying theme, however, is that all of these mutations auto-hyperphosphorylate that protein, that kinase, and you can dose-dependently block that autophosphorylation with kinase inhibition, leading to the hypothesis that you could potentially treat these disease entities with kinase inhibitors. For this fusiform aneurysm, he actually had an aneurysm in his radial artery that was harvested, and that allowed us to actually separate the cells of the aneurysm and say that definitively the endothelial cells marked by CD31 did not harbor the mutation in PDGFRB, but we only found those mutations in the vascular smooth muscle cells. And I should also add, not in the pericytes, which is very important because hemangiopericytomas, you actually have the variant in the pericyte of the tumor. This is very much different than saccular aneurysms. In sequencing saccular aneurysms, 0 of those have PDGFRB mutations, but you get recurrent mutations in collagen, extracellular matrix proteins, all of the genes that you would think of with connective tissue disorders. The interesting part there is that the allele frequencies of those variants across the big cohort of human aneurysms all fall between 5 and 12%. So something that would be completely missed by traditional Sanger sequencing. Real quickly, I have 1.5 minutes. We've extended this concept to the secretory adenoma. All the residents know we aggressively go into the cavernous sinus and try our best to cure these people surgically of their secretory states. We focused a lot in the lab on acromegaly and prolactinomas, because those are very difficult tumors to biochemically reform. And again, when these tumors enter the cavernous sinus, they involve blood vessels, nerves, dura, and the residents are sick of hearing me talk about the pseudocapsule, but the pseudocapsule is very important, and this varies between tumor to tumor. Some pseudocapsules are thick, some are thin, some harbor tumor cells, some don't. Some of these tumors invade the dura and the bone. And in fact, when you look at exome sequencing, you can predict which of these tumors retrospectively act poorly at the time of surgery and aggressively by looking at copy number alterations, again, down to levels that are less than 1% of the alleles. Lastly, for meningiomas, the lab has focused on 2 subgroups that are difficult to identify. One is the aggressively recurrent grade 1 meningioma. The pathologist tells us this is benign. You've cured the patient by taking the tumor out. And in fact, we have several cases. It winds up being right around 4 to 5% of our overall cohort where you get rapid recurrence. They don't respond to radiation. Why is that? Histologically, these tumors look identical. And in that same vein, atypical meningiomas, should we irradiate them? Should we not? 40% of them recur, and they recur aggressively and eventually lead to death in our patients. We don't know the answer to that. Histologically, these tumors look identical. We used a shotgun proteomic approach to look at the phosphoproteome, and the reason we did that is we tried exome sequencing. There are genetic alterations in a group of genes that don't predict aggressiveness in these tumors. And in fact, we found an alteration in retinoblastoma 1 gene on a specific phosphorylation site predicts recurrence in grade 1 meningiomas. And that's very significant. This is part of a prospective randomized trial currently here in our neuropathology department.
So for the talk today, I decided to speak about a new project in my lab. And this is a project that we develop and are working together on with collaborators at the Allen Brain Institute down the street from Seattle Children's. And as you can see from the title, this is a project that focuses on gene therapy in our mouse model of Dravet syndrome. And this we are using as a proof of concept in gene therapy. But before I talk about our gene therapy project, I would like to mention, and some of you know that the main focus of my lab is to understand the pathophysiology of genetic refractory epilepsies and their comorbidities. And the second fold of my research interest is to design and test future therapeutic for this very difficult epilepsy to treat. And so today, focusing on Dravet syndrome, I would like to say that this is a very debilitating type of epilepsy. And its clinical manifestations are very well known. They were first described by Dr. Dravet, who's seen in the picture there to the top right with me at a meeting several years ago now, about 5 to 6 years ago. And so Dravet syndrome is usually starts in the very first year of life. And throughout the course of disease, kids will develop multiple forms of seizures and several comorbid conditions. And very important for this particular talk too is that the seizures in Dravet are very refractory to most anti-epileptic drugs on the market. And in fact, some of the drugs are contraindicated, and this is the case for the listed here, carbamazepine, lamotrigine, because they aggravate the symptoms. And there is a very well-known unmet need for treating Dravet syndrome in the field. And so the Dravet syndrome itself is known from genetic studies that it's due to mutation, heterozygous loss of function mutation in the SCN1A, which is the gene that encodes the alpha subunit of the sodium channel NaV1.1, which express in the brain. And this mutation leads to haploinsufficiency of the gene product. And several years ago, during my postdoctoral training with the Catterall lab, we generated a mouse model of Dravet. And this was done by deleting a segment of the sodium channel protein shown here in the highlighted box. And this deletion leads to a mouse model that show a lot of key phenotype of Dravet syndrome. And so this is a very relevant model that has been established in the field. And so the work that I'm presenting today is based on our extensive study of the pathophysiology of the disease and our work in dissociated excitatory and inhibitory neurons shown that in the presence of the disease-causing mutation, cells in the hippocampus and especially inhibitory neurons have a reduced current, sodium current, as shown in this in this graph here. But excitatory neurons do not show any change in sodium current. And this, in turn, the loss of sodium current in inhibitory neurons make the cells less excitable. As you introduce more and more depolarization of current to depolarize the cell, you see that the wild type will generate more and more action potential, but those with mutation are unable to generate this firing once they reach a certain level. And so this is showing that there is an impaired excitability in inhibitory neurons following the Dravet syndrome mutation. This is what's led us to hypothesize that Dravet syndrome is a sodium channel interneuropathy, and this interneuropathy is lead to an imbalance of excitation and inhibition in the brain, and this is the cause for the seizures in Dravet. And so based on that, the hypothesis for the project that I'm presenting today is that sending an intact copy of NAV1.1 gene specifically to inhibitory neurons can rescue the phenotype of Dravet. And this is a daunting case, a daunting task. And but with our collaborations with colleagues and friends at the Allen Institute, we've designed some viral vectors that carry a sodium channel and that can be targeted to inhibitory neurons. And we are now testing this treatment using these viral vectors and testing whether we can rescue the phenotype in Dravet syndrome, and using two types of experimental paradigms. And we know that similar to what's happened in human, in our mouse model, we see that the mice are born without the disease, and the disease onset happened around P21. And there is a little bit of stabilization of the phenotype around P35. And so in the first paradigm, we'll study whether our treatment can stop the seizure, and this will be treating the mice following the appearance of the disease. And in a second paradigm, we'll treat the disease even before its appearance, and testing whether we can prevent epileptogenesis. And this will be by treating the mice anywhere before the P21 age. And our outcome that we'll measure will be the susceptibility of the mice to terminal seizure and the mortality. And of course, in addition to all of that, we will measure the immunogenicity and other consequences of sending this gene into the mouse, and see whether there is no complications of the gene therapy itself. And here I'm just going to show a couple of slides with preliminary data. Here we are showing that our vector can target inhibitory neurons, as you can see by this triple labeling of inhibitory neurons, GFP and anti-HA tag that is associated with our therapeutic transgene. And we see that at least one type of our treatment or of our virus label very well all the way into the dendrite of the cells. And when we test our mice, we see that against seizure threshold in the terminal seizure test, we see there is an increase in the seizure threshold of the mice when they are treated. And this is a very promising result, and we are conducting this work. And we hope to have very soon good news from the NIH that our grant will be funded. And but in the meantime, we have submitted an IP and have received an IP, and we also have interest from industry partners to buy the technology.
So great to talk to everybody this morning. So as most people know, my lab focuses on understanding glioblastoma, and in particular, trying to understand cell states and how those change during treatment using single cell analysis. And so the general directions of the lab, as I mentioned, are that we're interested in non-genetic sources of tumor heterogeneity. That is, things like cell state and how those change with time. We, in general, try to use patients as much as possible as our model system, and then sort of extrapolate from there as needed into additional model systems to confirm our findings. And we use single cell technologies and with a particular focus on epigenetics and transcriptomics throughout our work. And so the fundamental issue that we're trying to tackle here is that glioblastomas are remarkably heterogeneous on a cell-to-cell level. And, as you can see here, each cell is different from its neighboring cell in its gene expression profile and a variety of other downstream effects of that. And that creates a problem, which is that if we look at these things using bulk sequencing techniques, we only get an average readout of what's going on in the disease process, which can be very hierarchically organized. But if we use single cell analysis, we actually get a much more accurate readout of what's going on in the disease at the single cell level. And so the lab has focused on this in the past, and we're sort of now taking the next steps towards better understanding how this heterogeneity impacts things like treatment response. And I'll just kind of go over very quickly four kind of large scale things that we're doing in the lab, just to give you a sense of the types of things we're working on. So once again, we always start with the patient. This is an example of a patient that was operated on at the UW. We removed the tumor, the specimen's taken back to the lab, and we kind of pipe it into various downstream applications, including generating patient-derived xenografts, as well as single cell sequencing, and then generating cell lines from that. We also try to capture as much as possible patients at the time of recurrence, either through reoperation or in a special collaboration with Dirk Keen and PJ Semino to perform rapid autopsies on some of these patients. And so then, what do we do with this tissue? One of the things is we're trying to characterize the sort of microenvironment that these tumors live in, and we're doing this using as part of an atlasing project in collaboration with the Linnerson lab at the Karolinska Institute in Sweden. So we take the tumor specimen, we generate individual nuclei from this, and we put this through downstream applications, including single nucleus RNA sequencing and attack sequencing. As you can see here, once we've done that, we can sort of aggregate and dimensionally reduce the data and project it onto these sort of two-dimensional representations where each dot here is an individual cell, and cells with similar profiles will cluster together, which we can then sort of identify using known markers. And this just gives you a snapshot of kind of what's going on in the tumor cells, as well as in the microenvironment and the cell types that are making up the microenvironment. And we're trying to do this on a large scale for up to 200 glioblastomas. The next thing that we're interested in doing is trying to understand how these cell states change over time, and in particular with response to treatment. So this is an example of an experiment where we took a patient sample, we profiled it using the single cell techniques I just outlined. We then made patient-derived xenografts out of this patient's tumor cells. These xenografts we then subjected to standard of care therapy, including radiation and temozolomide. And as you can see here, there are cell states that are represented in the original patient and the xenografts, and these cell states will actually evolve over time with enrichment of particular cell states over others that are resistant to therapy. We can then use methodologies where we can try to understand gene regulatory networks within resistant cells, and then actually pair these gene regulatory networks with potential targets, which we can then go back and iteratively assess for efficacy in our model systems. One of the cell populations that's thought to be very important in recurrence are quiescent or dormant cells. And so we wanted to study this population. This is a collaboration with the Pattison lab at the Fred Hutch, where we took a whole genome CRISPR library and performed a screen in a cell line that has a reporter for quiescent cells. We were able to use this to identify a particular target, a histone acetyltransferase that is important in basically mediating or regulating entry and exit into dormancy in glioblastoma. And we've done a variety of downstream assays to kind of characterize the quiescent state in glioblastoma, including things like evaluating protein synthesis rates, as well as looking at global levels of chromatin acetylation. And this led us down the path of trying to understand ways of looking at chromatin changes at the single cell level. And so this is another collaboration that we have at the Fred Hutch with the Hennekoff lab, looking at a methodology by which we can do single cell histone mark-specific chromatin profiling. In this case, I'm showing single cell H3K27 trimethylation profiling of a patient glioblastoma. Again, we can see here that we can resolve a variety of cell types within a parent tumor. We can then identify these cell types using markers and try to understand the changes in histone-specific chromatin profiles that are occurring, both within a patient tumor and then over time. And the overarching goal of our lab is essentially to develop a paradigm where we can kind of use our patients to try to understand what's going on in a disease process, We operate on these patients. We generate single cells. We perform various downstream analysis techniques. We identify targets. In parallel, we develop patient-specific models of disease, and then we kind of test the targets that we've identified from the patient in these patient-specific models, and then ultimately the goal would be to feed this all back into rational treatment design for an individual patient. And so with that, I'll just acknowledge the people in my lab, Anka Mahalas, a research scientist who did a lot of this work, as well as a couple of the residents, Sam and Abdullah, who rotated through the lab, our several collaborators at the Fred Hutch and around town, as well as internationally, and then our funding sources.
Okay, so basically my lab is interested in how the brain controls breathing, and also breathing controls the brain. And we're pretty interested in one area, which is called Pri-Bötzinger complex, which sits in the medulla. And if you lesion that area with various techniques, then the breathing stops. So it's an essential area, and people have called it the nerve vital. So this area controls basically blood supply and lung activity, but it has to be coordinated not only with the lungs, but also with the heart. And so we know that basically each time you inhale, your heart rate goes up, and when you exhale, your heart rate goes down, and this is the so-called sinus arrhythmia, and it's a sign of a healthy coupling between the breathing and the heart. And this coupling is disturbed in many disorders like dysautonomia, and this is just an example from a child with Rett syndrome, and you can see that the heart rate variability is dramatically reduced compared to control children. And many of these dysautonomia disorders are actually also associated with intermittent hypoxia. So in particular in Rett syndrome, these are breathing traces. You can see these children have these breath holds, long breath holds, which then makes them hypoxic. But you have other disorders of dysautonomia, and one is obstructive sleep apnea, where you also have these desaturations coming in. Familial dysautonomia, another disorder with intermittent hypoxia, or actually even seizures. If you have several seizures in a row, you have also intermittent hypoxia. So the question we're interested in is, where is this coupling controlled and what is hypoxia doing? And interestingly, this area of the Pri-Bötzinger complex sits very closely to the area of the nucleus ambiguus, which controls the cardiovagal neurons. And in fact, what you can do is in a mouse, take this area out and put it in a dish, and it still continues to generate the breathing rhythm in isolation. So you have here these inspiratory neurons, and you can see above here these cardiovagal neurons. These cardiovagal neurons are inhibited by the Pri-Bötzinger complex in a rhythmic fashion. And so when we come back to this slide, you can see that these cardiovagal neurons are active during your exhalation, but then inhibited and inhibit the heart during your inspiration. So having identified these neurons now allows you to ask the question, what is hypoxia doing to this? And when you expose these mice to intermittent hypoxia for 2 weeks, you get an upregulation of HIF-1 alpha in this area. But interestingly, you get also oxidative stress. So if you record, for example, hydrogen peroxide production, you can see that during hypoxia, these neurons produce reactive oxygen, release it into the environment, and they create oxidative stress. And what this does to these neurons is that these neurons become inhibited. So they basically discharge much less, which means the heart rate will go up. And also because they're inhibited, the breathing doesn't interrupt it anymore, so you get a decrease in heart rate variability. And but this is very similar to what you see also in the patients. But the intermittent hypoxia affects also the network that controls your breathing itself. And so when you look at these neurons, you start to see that after intermittent hypoxia, they start to desynchronize and don't basically fully activate an inspiration, which is a big problem because the Pri-Bötzinger complex controls also your tongue. And what happens basically if this transmission is disturbed, you get an apnea at the hypoglossus level. And this is shown here. After intermittent hypoxia, you get these apneas, which then leads to an obstruction of your airways and obstructive sleep apnea. So what I showed you is basically that you have this center of breathing, controlling your hypoglossus, your breathing, your cardiovagal neurons, and all this is driven after intermittent hypoxia by reactive oxygen species. So the big question that arises is why reactive oxygen species? Why oxidative stress when you're exposed to hypoxia? And this actually relates to this year's Nobel Prize that was given to Greg Semenza, who got it for the discovery of HIF-1 alpha. But interestingly, HIF-1 alpha is a pro-oxidant. And in your brain, you have also HIF-2 alpha, which is an antioxidant. And if you are exposed to chronic hypoxia, like going up to the Andes or Tibet or something high altitude, you upregulate your pro-oxidants and your antioxidants, and you adapt to the situation. Now, in intermittent hypoxia, in contrast, you upregulate your pro-oxidants, but you don't upregulate your antioxidants. And so you get an imbalance and a damage due to oxidative stress. And so what I showed you kind of for intermittent hypoxia, however, is a very general phenomenon that applies not only to intermittent hypoxia, but also to other issues like heavy metals, air pollutants, and biotic stress. All increases oxidative stress and uses and changes your cardiovascular coupling. And in many cases, that also is associated with sudden death. So that brings me, of course, to SARS and COVID. This is a very anecdotal evidence from the internet, and I don't claim it's true or something, but this is a patient that contracted a COVID infection and then saw associated with this a dramatic decrease in the heart rate variability. And we know that COVID acts on these ACE2 receptors that are present in the brainstem. And we started now a collaboration together with Dirk Keen and Desiree Marshall to understand, what is COVID doing to the brainstem and this circuitry. And this is just a snapshot of what we're doing right now. So this is from a patient, we're starting to look at, these different areas that are important for breathing, the hypoglossus, and over here, the nucleus ambiguus and the Pre-Bötzinger complex. We're looking at microglia, and hopefully we get an understanding of what is associated with sudden death in these people. So the work was done here by my lab, and I have a lot of physiologists and also some clinicians in the lab. And this is actually Greg Semenza. We have a grant together, and then here we celebrate his Nobel Prize right in December. So thanks for your attention.
Very good. So I will talk to you a little bit about the work we're doing in the Neurosurgical Biomaterials Lab. Shown here is a picture of a couple of my students. We do a lot of work in the clean room at the Washington Manufacturing Facility, which is here on campus. And we've enjoyed taking advantage of a lot of the high-tech equipment that's available and all the resources at the University of Washington. The research in my lab is really primarily focused on spinal cord injury, with a few secondary projects related to spine surgery, but with spinal cord injury being the main focus. As we all know, there's both a primary and secondary injury cascade, and our treatments are very limited. We can do early surgery, decompression, and stabilization. We can focus on MAP goals. Our only medication is IV methylprednisolone, and it's very controversial for low efficacy and high systemic side effects. So the primary objective in my lab is really focusing on local drug delivery and engineering new devices for local drug delivery. And we've developed a number of technologies for that purpose. One concept we've been working on for a number of years is this idea of transdural microneedles. And I had this concept while operating and thinking about different devices. I'm certainly not the only person who is interested in some concept of local drug delivery to the spinal cord. But there really hasn't been another demonstration of something that you could implant epidurally that then could deliver drugs intrathecally. And so what I wanted to do was have a platform where we could deliver something just like that. A surgeon at the end of a case, end of doing a laminectomy infusion, could implant a device epidurally that would then pierce the dura and just deliver drugs where we would want in the intrathecal space. So that required a lot of engineering to try to bring these devices to fruition. Again, we use the WNF quite a bit. We use 3D fabrication using 2 photon lasers and 3D photolithography. Here's just an example of a manufacturing process that we use to make a conductive polymer microneedle system. Here's an image of an actual microneedle array that we've built. We can manufacture these to any size. For the moment, we have been targeting the appropriate geometry for rodent implants, which is on the order of several hundred microns, but there's really no limit to the dimensions that one can make these sort of needles. Then the next question was whether we could prove that we could encapsulate and release drugs on command from these type of systems. Here's an example with dexamethasone, where by applying a voltage from this microneedle array, one can control when dexamethasone comes out, and if you don't apply that voltage, almost no drug is released. Then we wanted to develop an in vitro model of delivering transdurally. So that was actually pretty challenging as well, just to be able to test an array of parameters and prove our system could work. So we 3D printed these transwell inserts. We use a dural substitute, DuraMatrix, which is commercially available and used in humans. And we separate a chamber that's filled with either saline or where we grow cells from a model epidural space. And then we apply our device either with or without an applied voltage and see whether we can deliver drug and then if there's any biological efficacy. So here's an example with the transdural setup. At the bottom of the wells, you can see cells located there, and we to model neuroinflammation, we expose the cells to an inflammatory environment, and then we measure their production of nitric oxide as well as a number of inflammatory cytokines. This is an example of nitric oxide release, and we showed that with our system, again, implanted in the epidural space, we could have transdural delivery and knock down nitric oxide release into the equivalent level of a positive control of a subdural dexamethasone solution. Similarly, we could knock down production of inflammatory cytokine. Here's an example of IL-1 beta. There's a lot of technical details that are important here. One is the type of voltage one uses to release these drugs from these systems. And one can apply DC voltage versus something called cyclic voltammetry, where you cycle between positive and negative cycles. And we found that by using a cyclic voltammetry type delivery setup, we could have a smoother and more controlled delivery and still achieve some of the same results. We also wanted to develop a dissolvable system, which would not need to have an external power system. And so we've done that with a PVP PEG diacrylate hydrogel system. We did this by making three-dimensional molds and then implanting our drug and then UV polymerizing it. Here's a SEM image of what those look like. And we also showed similar efficacy in downgrading inflammatory cytokines with this type of system. Separate from the acute setup where one might be interested in delivering anti-inflammatories, I'm also interested in kind of the longer term in chronic SCI, where you might be more interested in drugs that could promote rehabilitation. Recent years have led to a lot of papers looking at epidural stimulation without drugs, just as a concept for promoting rehab after spinal cord injury. And I was interested in combining our technologies with that concept and possibly delivering drugs during rehab. So we have separately developed some chambers for testing delivery of quipazine, which is a serotonin agonist and thought to promote plasticity during rehab. Here's an example of some chambers we're using in our device that we in our lab, which we've custom fabricated, and then some microelectrode arrays that we've custom fabricated for the same purpose. Also some more technical details, but actually measuring new drugs and being very specific is challenging. A benchtop system that commonly uses UV vis absorbance, but actually it's not very specific. So we've had to adapt to more advanced chemistry techniques. In this case, we use HPLC and mass spec to more specifically detect our drug of interest. And we've shown now with quipazine that we can also encapsulate and release this from our system. So in terms of something I envision as the future of SCI treatment is that for chronic SCI, ideally we could implant epidural stimulators that at the same time would deliver drugs of interest that would promote neuroplasticity, with quipazine being one example. As a totally separate study, we've been looking at 3D gait analysis of patients after certain spine surgeries. Here's an example of a patient coming into the amplifying motion lab at UW and us testing 3D gait analysis. And we're interested in seeing what are the surgical effects of deformity correction and whether that can improve gait. So I'll stop there, just kind of an overview of a few of the projects. We have a number of different projects falling under the same domain of drug delivery for different purposes, including pain and spine fusion.